developments in drug-eluting balloons. Thank you. So we'll kick things off by talking about drug-eluting balloons, which looks like we're on the verge of having available in this country. No disclosures for this topic. So this is a list of 27 studies, current studies, using drug-coated balloon or drug-eluting balloons for peripheral vascular therapy that are registered with clinicaltrials.gov. This doesn't include trials that are already completed or trials that are developed since that listing or future trials. But this represents kind of a mechanistic analysis of the trials that have been completed with several different vendors and several different platforms. So the lesions in these studies were on the shorter side, 60 to 100 millimeters, which is the red bars. Mostly stenotic rather than occlusive disease. So 12 to 40% were CTOs, that's the black dots. And they showed a statistically significant reduction in late loss with drug treatment as compared to plain old balloon angioplasty. Drug treatment is the blue bars, yellow for control. Angiographic analysis shows that the restenotic lesions that do develop after drug-eluting balloon therapy tend to be focal and therefore more amenable to secondary treatment. The focal restenotic lesion, as opposed to diffuse restenosis, may allow for enough flow to minimize symptoms and the need for repeat revascularization. This may account for the gap between the study restenosis rates determined by ultrasound or angiography that were much higher than the clinical target lesion revascularization rate. So perhaps for the patients, their primary concern is whether or not they have to undergo another procedure, but for the endovascular specialist, a big concern is what type of procedure has to be done and how likely that second procedure, if necessary, is to be successful. So 2 slides here on the clinical outcomes for the Lutonix flavor of drug-eluting balloon. This, like the others, is a paclitaxel eluting balloon, almost 500 patients. What they showed at their 6-month endpoint was a higher primary patency for drug-eluting balloon as compared to POBA, and a lower restenosis rate. Safety was equivalent. The 12-month outcomes for the same cohort of patients were evaluated in a blinded fashion. And again, the primary patency was much higher with the drug-eluting balloons than it was with POBA. Restenosis was less, and safety was equivalent. So based on those studies, a month ago, the FDA panel voted to unanimously approve the Lutonix drug-eluting balloon for device release. It's reported that there were some concerns in the panel about the analysis of the study, the intention to treat versus per protocol analysis, and the relatively lower benefit that was seen in female patients. So the FDA panel is a group or a body of experts that are recruited by the FDA to review and analyze the studies that are submitted for regulatory approval. Their vote is usually followed by the FDA, but approved by the FDA is pending and is not necessarily bound by what the panel finds. So the Washington bureaucracy moves in slow and mysterious ways. Hopefully, in this case, they will not lose their hard drives, servers, and backup tapes like the IRS did. Stay tuned. It's looking like we'll probably have a drug-eluting balloon in our hands before the end of the year. Next up on the likely candidates is the Medtronic Admiral drug-eluting balloon. Their one-year trial results are presented here. 331 patients with SFA disease were treated in Europe and the US with the Admiral paclitaxel balloon. The mean lesion length was 91 millimeters. Primary patency is freedom from TLR and freedom from stenosis measured by ultrasound. Note that for the balloon group, roughly half of the patients with stenosis ended up with TLR, whereas for the drug-eluting balloon group, about 1/10 of the patients who had stenosis ended up with TLR. So to me, that implies that even when stenosis was present in the drug-eluting balloon group, it was less symptomatic, probably because it was less tight or less long. Clinically driven TLR was for symptoms or for a big drop in ABI. This TLR of 2.4% for the drug-eluting balloon group at 1 year is the lowest of any SFA intervention that I know of. MACE was death, TLR, major amputation, and thrombosis, and in this case was driven by the TLR in the balloon group. Some of the older studies were looked at in a meta-analysis. Consistent findings. The patients who were treated with the drug-eluting balloon had lower TLR compared to those treated with plain old balloon angioplasty. Safety was equivalent. The decrease in TLR was driven by a decrease in restenosis. So will there be a catch-up effect over time like we've seen with the drug-eluting stents in the SFA? Don't know yet, but it's promising that since there's no stent left behind and there's no ongoing inflammatory response to that stent, that the results, I think, will be likely to hold up over time. So the preferred drug so far is paclitaxel. It's virtually insoluble in water, and it comes in a microcrystalline form. So in drug-eluting stents, the drug is slowly released from a polymer coating and has a local effect of inhibiting scar tissue formation at the site of stent implantation. This works in coronary stents. An attempt was made to coat a coronary stent with paclitaxel without the polymer delivery. That was a big failure. There was no difference between dipping the stent in paclitaxel without a polymer versus a bare metal stent. In the peripheral side, the advanced PTX trial used a drug balloon without any excipient. That is a coating that's designed to deliver the drug to the vessel wall. Basically dipped a balloon in paclitaxel. In that advanced PTX trial, there was no statistically significant benefit for drug delivered that way as compared to POBA. There was some trend toward benefit, and there were some subsets that did benefit, but it really wasn't very effective at all. Based on that, I would presume that any delivery system that fails to trap enough drug in a usable form for a long enough time will fail. So that would seem to rule out any schemes such as weeping balloons or double balloons with an infusion chamber between them. So that brings us to the current state of the art. On one hand, the balloon must have the drug attached strongly enough so it doesn't get dislodged during transit from the factory, during going through a catheter in the valve, or during delivery through a pulsating and flowing artery. On the other hand, the coating has to be attached loosely enough so the drug can get imprinted into the vessel wall. On the other hand, the drug must not be attached so loosely that it ends up downstream and becomes ineffective or toxic. So this is a model system that's designed to measure the looseness of drug attachment to the balloon. Missing a picture here. Well, anyway, findings from using that model system were that different balloon systems have a different rate of drug flaking off or getting loose and downstream. Is this a clinically important effect? We don't know. But it does show that there will be differences in the design and materials that are used to make these catheters, and that will make a difference in the engineering, the manufacturing, and the marketing. Will we have trials comparing one system to another? I doubt it. So how will we choose which brand of drug-eluting balloon to use? My bet is that hospital administrators will choose for us based on price. Oh, there's my pictures. So one drug-eluting balloon system versus another, and the particulate release downstream. So in conclusion, the future directions, based on what we've seen so far for drug-eluting balloon trials, have shown a consistent and strong, but not perfect reduction in the restenosis of the femoral popliteal vascular bed. Will we see a restenosis benefit in tougher challenges like long occlusions, in-stent restenosis, heavily calcified vessels? Does the drug design and manufacturing really make a difference in efficacy? What's the utility of these drug-eluting balloons in other vascular beds? Drug-eluting balloons appear to be safe, but will balloon disruption or coating embolization, especially when it's applied to unusual situations, become a concern? And how will drug-eluting balloons interface with atherectomy, stenting, or other new technologies? Will drug-eluting balloons become an add-on technique or a primary procedure with rescue using other techniques? We just don't know yet. Thank you very much.
Thank you, Mike. Our next presenter is going to be Dr. Prakash Krishnan from New York. And Prakash is going to be talking to us this morning, or this afternoon rather, about the 4-year primary patency data for Zilver PTX.
Thank you, Dr. Sukas. I'd like to follow up that nice lecture on DEB with some talk about drug-coated stents. So drug elution now in the periphery. Well, you know, you've got multiple drug-eluting stent and drug-eluting balloons going on at this time, and multiple companies with peripheral drug-eluting technologies that are currently under evaluation. As you just heard, there's a couple of trials that have been completed, but there's nothing ready for prime time yet. So as of now, Cook Medical is the only company to offer any drug-eluting stents for the superficial femoral artery. So the Zilver PTX drug-eluting peripheral stent is currently available, and I just want to tell you a little bit about it. It's a newer generation SFA stent, and it's available right now in over 50 countries. It's approved in Europe as well as in Japan and the US. So it, unlike the coronary drug-eluting stent, it does not have a polymer. It has a scaffold plus the drug, and it's a mechanical scaffold, which is a Zilver Flex stent platform. And the drug, as was just presented, is the paclitaxel one only with no polymer or blinder, which differentiates it very clearly from the coronary stents. There's 3 micrograms per millimeter squared of dose density, and the trial that I'm going to talk about was sponsored by Cook Medical and is really a landmark trial. So the design is really very insightful in that the trial designers really thought about the future. So at that time that the trial was performed, there was no FDA-approved non-drug or bare metal stent for the SFA. So initially, it has 2 types of randomization, a primary randomization and a secondary randomization. So the primary randomization was the Zilver PTX versus optimal angioplasty. And if you failed angioplasty, as meaning if you had a dissection, you had recoil, you had a suboptimal result with a 30% residual, whatever it may be, you had a secondary randomization to a provisional bare metal stent or a provisional Zilver PTX. So therefore, you're always comparing the same scaffold, which is important, as you saw earlier with the durability 2 data, as compared to the Zilver. So you compared a non-coated stent with the same stent that was coated with paclitaxel. So you're really comparing only the drug. So it was very, very important randomization. So if you look at the demographics and comorbidities, you know, the number of patients was a good size. Obviously, age, male. You can see the number of diabetics and smokers were also pretty even across the arm, so there was no real confounders. And if you look forward in terms of lesion characteristics, important thing to note here is obviously your lesion lengths. They're not as long. You know, they're about 63 millimeters in the angioplasty arm versus Zilver PTX was 66. But if you look at, more importantly, what I consider real-world type lesions, where you have occlusions, you have calcific lesions, you can see that they treated a lot of real-world lesions in this particular study. So the one-year data look good, but we're really here to talk about 4-year data, so I'm just going to go right to the 2-year data. If you look at the 2-year data as defined by primary patency as a PSVR of less than 2.0, you can see it was 74.8% in the Zilver PTX arm versus 26.5% in the angioplasty arm. So having said that, let's talk a little bit about the 4-year results. And so it's important for you to understand the structure of the trial and what the trial was intended to compare. That's why I spent a little time there. So at 4 years, this is probably some of the most exciting data because we've got long-term follow-up of a randomized clinical trial. So I want to focus on a few things. I think one is freedom from TLR, which was spoken about earlier as well. Primary patency, which may be different than freedom from TLR, but still is a very important clinical variable. Lesion length, how does the stent perform on different lesion lengths, and diabetics. So let's look at the freedom from TLR and the primary patency as defined as PSVR less than 2.0. So if you look at the 4-year freedom from TLR, Zilver PTX versus standard of care, as of the drug effect, looking at both the primary and secondary randomization, that's looking at optimal PTA plus BMS versus Zilver PTX, you can see here the freedom from TLR in the Zilver PTX is statistically significant at 83.2% versus 69.4%. If you look at just the secondary randomization, which is now comparing bare metal Zilver or bare metal Cook stent versus the Zilver Cook stent, you're looking at, as PSVR less than 2.0, 75% versus 57.9% with a p-value of 0.04. If you look at the primary patency, Zilver PTX versus standard of care, as just defined by ultrasound criteria, which is incredibly important. Again, you look at a statistically significant difference of 67.6% versus 45.5%. Now, so without a doubt, there is a drug effect, okay? And, you know, I should have actually gone over the drug effect on you guys. I skipped that. But the point is, there is clearly a drug effect around anywhere from 40 to 50% in each one of those things that we talked about. But if you look at the 4-year results of Zilver PTX versus standard of care, you also want to look at the lesion lengths and how the stent performed against various lesion lengths. So if you look at lesions greater than 7 centimeters, okay, which again, people were saying the SFA is not that long, but clearly we need to have data in all different lesion subsets. So if you look at lesion subsets and just freedom from TLR, you can see the standard of care on the bottom left, or to my left, I guess it would be to your left as well, is 70.6%, less than 7, 63.4% for standard of care for greater than 7, and Zilver PTX was 84.9 and 79.5 respectively. So Zilver PTX are similar, the patencies are similar, or results with TLR are similar in both less than 7 centimeter lesions and greater than 7 centimeter lesions. If you like to look at longer lesions, greater than 10 centimeter lesions, again, looking at freedom from TLR, it's 83.3% and 82.4%. So Zilver PTX results are similar in lesions less than 10 and greater than 10 when it comes to freedom from TLR. So if you compare that to standard of care for lesions greater than 10 centimeters, it's 44.9% versus the two numbers, 83 and 82%. So there doesn't seem to be any change in the PTX results whether they're less than 10 or greater than 10. And definitely, it's clearly superior to standard of care lesions in 10 centimeter lesions. If you look at primary patency as defined by PSVR less than 2.0, again, this trend carries through. If it's around 48.4% in the standard of care in lesions less than 7 centimeters, and greater than 7, it's around 40%, 38.3. And again, Zilver continues to be superior at 70% and 61.7%. So again, if you look at PSVR, if you look at TLR, the Zilver PTX results are similar in lesions less than 7 and greater than 7. And again, did it move? No, it did not move. And again, if you look at 10 centimeters, this again carries through as well, although and also as profoundly as it did with just TLR. With lesions greater than 10 centimeters, as defined as primary patency, as defined as PSVR less than 2.0, in the standard of care was only 36.4, while the Zilver PTX maintained its advantage at 67.6 and 67.7. So again, whether it's TLR or PSV, you're still having a continued superiority in the Zilver PTX on. So what about in diabetics? We talked about it earlier in the definitive LE data where you saw that there was an effect on diabetics, which as we know as interventionalists, especially vascular interventionalists, we deal with the adverse outcome in diabetics. Again, we were pleasantly surprised here when you looked at the freedom from TLR in diabetics patients that there was really a very minimal difference between the two. And if you looked at the primary patency, the diabetics versus non-diabetics, it was clearly seen that Zilver PTX results are similar in both diabetics and non-diabetics. So in conclusion, it's presented a lot of data to you, but I just want to hammer home the take-home points. Okay, the 4-year results support sustained safety and effectiveness of Zilver PTX with no late catch-up. We've always had the excitement of an early trial showing some good results, and then we have late catch-up. So I guess this is very exciting, and I'm very curious to see what's going to happen with the DCBs as far as the late catch-up is concerned, especially with the randomized trials that have been completed now. The trial clearly showed significantly lower TLR rate and significantly higher patency rate than standard of care therapy. And we looked at 2 forms of standard of care. One was obviously optimal PTA or Zilver PTX versus optimal PTA plus stent. And then you have Zilver PTX results are similar in diabetic and non-diabetic patients. And Zilver PTX results are superior to standard of care in lesions greater than 10. You have significantly higher patency rates than BMS, and you're greater than 40% reduction in restenosis due to the drug effect. So it's a effective, safe stent that has proven data in a randomized trial format and with great follow-up out to 4 years. So it clearly should be an important part of your armamentarium. And it's also a pleasure for us endovascular interventionalists to be able to give our patients another option beyond what we just have. I thank you for your attention.
So it looks like we're going to be going back to Dr. Woolley in Pittsburgh. So hopefully Mark's back with us and give us the follow-up results on that patient that was done earlier today. Mark, are you there?
We finished the procedure, and Gus is going to run through it with you. We finished the procedure, we used the Pioneer to enter, and then subsequently we switched out the 014 Pioneer wire for an 035 Woolley wire, positioned that in the external iliac, and we did all this stenting with SmartFlex and one complete from the popliteal approach. And we just finished closing the popliteal with Perclose. So we're losing here, just I'll put a little manual hemostasis. So anyway, you can see the run now. We got a pretty nice result. He's got great tibial outflow, but he had that to begin with. So we think with that great tibial outflow and wide open lumen now, we should get a pretty good outcome. What is interesting is that I know we were in the false lumen. You can see that convex bend there right in the middle SFA. And that's definitely extraluminal. But I'm surprised that some of it looks like it's intraluminal. And who knows? It's tough to tell false lumen from true lumen, but obviously it's a very good result. You can see it there. Run it again. There it is there. You can see. And this is a very badly calcified SFA. We're lucky to get through it. Okay?
Yeah, that's a great result, Mark. Thanks.
All right, thank you, guys. See you.
All right, it looks like we're going to be going to our next lecture, and it's a real pleasure for me to introduce my good friend, Dr. Eric Dipple, who is going to talk to us about laser atherectomy for FemPop in-stent restenosis. And Eric really has been a pioneer in this field and and still is the national principal investigator for the Excite ISR trial. So, Eric, we really look forward to hearing about that.
Thanks a lot, Peter. So I think, I think to take a step back and look at how we got to this point, when you look at the histology of new intimal hyperplasia, it actually has a very high water content. It's only about 15% cellular, about 85% extracellular matrix. There's a very large amount of proteoglycans and other proteinaceous structures that are in the extracellular space that attract water. And for a while, we've kind of theorized that what happens when you simply dilate this. And actually, this is a nice study that was done by Gary Mintz's group on coronary restenosis about 10 years ago or so. Most of us, when we dilate coronary arteries for in-stent restenosis, take a picture and we pat ourselves on the back and we walk out of the room and we say everything looks great. But what they actually did is they came back 30 minutes later and they re-angiogrammed these and re-IVUSed them and tried to understand what happens to them. And I think this is important. If you look at the top panel on the right, you see the IVUS area of the stent and of the plaque before angioplasty, immediately after, and then 30 minutes later. And there's no essential change. In other words, the stent itself doesn't change in diameter, the plaque itself doesn't change in diameter much. But when you look at the bottom panel, what you see, the open square boxes are the luminal gain, and the dark squares are the neointimal volume or neointimal area. And all of the luminal gain comes from compression of the plaque, and by 30 minutes later, the plaque is re-expanded. In other words, all you're doing with the balloon is squeezing the water out of the neointimal tissue, and within a very short matter of time, within a few minutes, the plaque begins to rehydrate, and all of a sudden you've lost your luminal space again. So plain balloon angioplasty for in-stent restenosis really doesn't work. That's the take-home message. And so the purpose of the Excite study was to look at using laser atherectomy plus balloon angioplasty for femoral popliteal in-stent restenosis. And so I'm going to present the acute results of this study right now. I'm as Peter mentioned, the co-investigator along with a good friend of mine, Craig Walker. I've listed all the other sites that have participated. I'm greatly thankful for all their help. The study was a prospective multi-center randomized controlled trial for the treatment of femoral popliteal artery in-stent restenosis. Patients were randomized in a 2-to-1 fashion between the excimer laser plus angioplasty versus angioplasty alone. It was anticipated by statistical modeling that we would need up to 353 patients. However, there was built-in stopping rules at analyzing the data at 200, 250, and 300 patients. This is an FDA-approved IDE study that was overseen by a steering committee as well as a data safety monitoring board and a clinical events committee. The angiographic and ultrasound core labs were sent out for independent adjudication of the data. The study design was fairly simple. Patients were screened, and if the lesion was crossable with a guide wire, then they were randomized, as I mentioned, in a 2-to-1 fashion. The FDA was very keen on whether or not the wire was behind the stent struts, and so that was why they had to have the lesion crossed first before we could randomize the patients. If you're unable to cross the lesions with traditional guide wire techniques, the patients were allowed to be enrolled in a total occlusion registry where we could use a step-by-step technique to cross through the stent. The devices that were used were the Turbo-Elite catheter and the Turbo-Tandem catheter, which you're familiar with. And the primary safety endpoint was major adverse events through 30 days, which were death, unplanned amputation, and TLR. The primary efficacy endpoint was freedom from TLR at 6 months. Secondary endpoints were acute procedural success, 6 and 12-month target vessel revascularization, primary and assisted primary patency rates, secondary patency rates, ABIs, and other clinical markers as listed there. The key inclusion criteria, the lesions had to be over 4 centimeters in length, Rutherford class 1 to 4. The diameter of the artery had to be between 5 and 7 millimeters, and they had to have 1 patent tibial artery to the foot. Key inclusion criteria was that the target lesion extended beyond 3 centimeters from the stent margin. Again, the FDA was very keen on having this be an ISR study and not a de novo study. And whether they had significant stent fractures also another exclusion criteria. Follow-up was at 30 days, 6 months, and 1 year. The study was terminated after 250 patients due to a statistical success of the primary endpoint. Here's the patient demographics. The patients were balanced for all their demographic variables. There was actually a higher proportion of smokers in the angioplasty alone arm, but otherwise they were all matched. Approximately 2/3 of the patients were Rutherford class 3. The baseline lesion characteristics, and I think this is an important data set here, is that the mean lesion length was almost 20 centimeters in both groups. I mean, this really treated the entirety of the SFA. That we had lesion lengths that were up to 40 centimeters long. This was a true real-world study. These were not short, simple lesions. These were treating patients that had full metal jackets in their SFA. And actually also, I think I want to point out that there was actually 3 times more patients that had severe calcification in the laser group compared to the angioplasty group. And that's an important distinction because, you know, one of the things is that many people say that laser is not effective at treating calcium. Although calcium was not intraluminal, many of these arteries were severely calcified. So the acute procedural success was statistically significant in favor of the laser group regarding the procedural success, and primarily driven by bailout stenting and dissections. Looking at percent diameter stenosis post-treatment, it was statistically in favor of the laser group versus the angioplasty-only arm. And looking at procedural complications, statistically significant throughout all major categories in favor of the laser, including procedural TLR, any dissections, particularly grade C dissections, and the need for bailout stenting. There was no statistically significant difference in the incidence of embolization, thrombosis, or acute closure. So in conclusion, neointimal hyperplasia is approximately 85% extracellular matrix with a very high water content. Balloon angioplasty for in-stent restenosis achieves acute luminal gain through compression of neointimal tissue, and acute loss occurs within minutes after POBA, primarily due to rehydration of the tissue. The Excite study demonstrates debulking is superior to balloon angioplasty for in-stent restenosis. This is the first FDA-approved IDE randomized control study demonstrating the benefits of atherectomy in the lower extremities in either de novo lesions or restenotic lesions. However, I do believe that with the stent still there, there's going to be a late catch-up, and this has been discussed in the past, as that I think that there will need to be an anti-proliferative therapy applied, and this is being actively studied. The PhotoPack study in Europe is enrolling patients, and that looks at laser atherectomy, debulking, followed by drug-eluting ballooning. Having said this, these are the acute results of the study. The 30-day and 6-month data is completed. The manuscript has been submitted to Jack. I'm not allowed to reveal those results until it's been published, but I can tell you that it was a very positive study, and I'll leave it at that. Thank you for your attention.
It looks like we are going to, in fact, go in order. So, Amir's going to talk to us this afternoon about drug-eluting bioresinosis vascular scaffold and share with us the exciting results, hopefully, of the ESPRIT trial.
Yeah, so thank you. So I'm going to talk about the bioabsorbable scaffold. You've probably seen this slide several times. The SFA is one of the more difficult vascular beds to treat, and for us to have any long-term durable result. The reason for that is, as you can see, the vessel is very dynamic. It twists, it torques, it has curvatures and multiple flexion points, and this causes a problem when we're trying to treat these vessels. The goals of a minimally invasive treatment of the SFA is acutely you want to reestablish flow and a uniform vessel appearance, minimize closure or geometric disturbances. The long-term outcome is, of course, we want long-term patency with decreased chance of restenosis and thrombosis. And also, you always want to leave the option for future therapy should your initial treatment not be successful. It's for this reason that the bioabsorbable scaffold was being developed. It was designed to meet these physiologic and clinical needs. The clinical goals is to reestablish flow, restore natural vessel function, vasoactive motion, and so forth, which can be compromised if we use stents. The physiological needs are obvious, and the scaffold provides a function that gives you radial support acutely, and it naturally resorbs. So this scaffold, you need it acutely, but over time, I'll show you it can be detrimental to the vessel. So what happens when we stent vessels? The vessels are in areas of high stress. One of the main limitations of using stents, or nitinol stents in the SFA, is restenosis and fracture. It's partly because of the SFA and partly because of the stent, and we'll show you at least the hypothesis is why we see so much restenosis with stents. This is just one article by Dr. Shiner showing that the prevalence of stent fracture in 121 patients. So it's actually, when you're stenting long lesions, the incidence of stent fracture is extremely high. So this is some of the hypotheses. So what happens when you put a nitinol stent in a vessel? If you put a nitinol stent in an oversized stent in the vessel, what happens is, if you see, this is an 8mm stent. If you put it in a 6-7mm vessel, you see what happens. If you put it in a 5mm vessel, you get restenosis much more aggressively and much sooner. And thinking is that when this constant force is pushed on the vessel, that's the nidus for irritation and inflammation, and that was demonstrated very nice in this animal model. What happens to drug-elution? It reduces the acute reaction, the inflammatory response that you see when we put these stents in. However, when the drug is gone, you still have this force pushing against the vessel and provoking inflammation. So why do we need the bioabsorbable scaffold? I think that we could do better. If you look at stents over time, this is the trials that we have with the stents. The patency at 5 years is, depending on what trial, but approximately 59 to 60%. So we could do better. If there's cardiologists in the room, know the evolution of angioplasty from the initial angioplasty, and then we made advances with bare metal stent, then drug-elution with the Ziver, and with each advancement we'd have significantly better results in regards to durability. So this is an ideal, what we'd want acutely and long-term. You'd want something that could give you an acute result, maintain radial force, and continue and give you good flow and resolve over time and not act as an irritant or something that inflames the vessels, cause restenosis. So this is a little bit, I'm going to talk about the trial, but this is actually the stent. The scaffold, the stuff is not really a stent, it's a bioabsorbable scaffold. It's made of PLLA or poly-L-lactide. It has a coating on it, and the drug in this particular stent is everolimus. The delivery system is the OmniLink, which you guys used before, and it's on 035 platform. It's designed such that it gives you radial force, and it also has links in it that gives deliverability. If the links, we've noticed some fracture when you're putting them in, it was reported from the European data, but the links aren't there for stability. It's the actual struts is what provides the radial force. So this is the functionality acutely. You restore flow, you stabilize the vessel, and over time, you want this thing to dissolve and not be in a footprint to cause inflammation. So this is an interesting slide from the Europeans showing that what happens to the vessel after 4 years. So after 2 years, you have the actual scaffold is dissolved, but if you looked at the vessel, you would still have footprints. You could see where the struts were. At 4 years, you see that there's no, it's indiscernible to see where the stent was. So it takes time and time to recover beyond that. It's actually very durable. It's tested like the other stent. So we'll talk about the actual data and the design. This was a prospective single-arm, multi-center trial. It was only done outside of the U.S., looking at claudicants, Rutherford class 1 to 3, and their lesion lengths were very short, relatively short to what we see in every day. Lesion lengths had to be less than 50, and vessel diameters 5.5 to 6.5. And you can see how they monitor these patients clinically, angiographically, and there were some small sub-studies. Clinically, they were monitored at 1, 6, 12 months, 2 years, and 3 years. And in process, I'm going to share with you the 1-year data, and they have 1-year angiographic data. So the objective was to evaluate safety and efficacy for SFA and iliac vessels. The procedural and the endpoints were procedural, clinical, functional, hemodynamic, IVUS, and non-invasive at those time points listed. So inclusion criteria was pretty simple. You had to be a claudicant, Rutherford class 1 to 3, had to be a de novo lesion. It could be a total occlusion. Had to be short, less than 50 millimeters, and the vessel diameter had to be 5.5 to 6.5. Exclusion was CLI. If you had ulcers, you're unable to ambulate if you had a total occlusion in the inflow in the ipsilateral vessel, or you had severe, moderate to severe calcification. This was done outside the U.S. You could see most of the patients were enrolled in Belgium and in Germany. There was a few patients in Austria and France. A very small N. The patient average age you could see, so this is kind of typical patients that they have all the potpourri of comorbidities that you would see in your practice. Here's the characteristics. The majority of these patients in this trial were used with the SFA, distal SFA. The lengths were short, 35, 36 millimeters. And here's the endpoints at 1 year, in 6 months. So you could see at 1 year the target lesion revascularization was 8.8%, which was 3, and there was 1 scaffold thrombosis. The scaffold thrombosis was attributed to having bad inflow in that particular lesion upon retrospective review, and also having malapposition in a undersized scaffold in a bigger vessel. This is the clinical endpoints. You can see the claudicant. If you look at Rutherford class 0 and 1, that included about 85% of the patients, so you had a significant improvement. And as you would expect, the Rutherford 3s had the most benefit. You can see the ABIs is an objective way to evaluate it. ABIs are markedly improved normal compared to baseline. The ultrasound data supports it, and this is a binary restenosis rates of 12.9%, 4 out of 31 at 1 year. So the reference vessels were 5 millimeters, and end segment restenosis, I think this was based on quantitative angiography, was 35% of the vessel. So the conclusions from the SPRI at 1 year showed it demonstrated it was safe without any deaths or amputations, low recurrence of revascularization, sustained improvement in claudication, and sustained ultrasound patency. Angiographic stenosis was at 1 year was lower in the smaller vessels, where the scaffold was matched appropriately to the vessel diameter. So the final thoughts: self-expanding metallic stents can impart chronic injury on the vessel by that continuous outwards force by the nature of the properties of the nitinol. Drug-elution is effective while it's in the tissue, but beyond that, you're left with the bare metal nitinol stent, which could cause problems. And fully resorbable scaffolds have the potential to resolve these issues. You could get sustained lumen dimension, allow time for the walls to heal, and not leave any kind of mechanical footprint. That's my daughter, so hopefully when she's an interventionalist one day, we'll have sorted out the SFA.
Thank you very much, Amir, and she is adorable. Okay, we're going to be switching over to our live case, and we're ready for you, Jack. Do you have an interesting case for us?
Hello, hello. Welcome back again to Lexian Brothers. Ready to get going with our last case. This gentleman, 71-year-old gentleman who came to us earlier in the year with a totally closed left SFA and lots of claudication at short distance. He actually had not a lot of calcium. It was a good case for ocelot, so we used the ocelot device, got across nicely, and then followed with debulking with Silverhawk. And we didn't do anything else. It looked pretty good, and he did fine. It didn't last very long. This is 4 months ago, and he started having more pain recently, and really can't walk very far without left calf pain. So we brought him back. His ultrasound showed he had a restenosis in the left leg, left SFA. So let me show you the pictures we have here. So he has, let me go forward first here. Hold on a second. He has a little bit of a profunda lesion there that might be why his collaterals aren't doing the full trick here. And he's got bad restenosis really right where it first starts there in the SFA. That was our original proximal cap. And then you see we have not a bad little spot, then it restenoses more. And then as you see here further down, it gets very, very tight. And I'll give you the bone there. You see kind of getting close to the distal end of the vessel. Then it comes back again and is a pretty good looking artery. And he's got 3 vessel runoff. So this is kind of this whole restenosis issue. This is a fast restenosis. And sorry, our distal vessels don't light up too hot, but they're there. Fast restenosis in a highly restenotic type of segment. You know, it's these long occluded SFA. What does the panel think? We have a few ideas what we think we ought to do, but love to hear from you.
All right, we'll go ahead and open it up to the panel right now. So why don't we start at the end and we'll work our way down. Okay, what do you think, PK?
I mean, this is obviously a case, Jack, that you've already done a form of atherectomy, and you've had aggressive restenosis. So I think, to me, this is a good, it's not at the flexion point for a first stent, so I think this may be a area where I would use a Zilver PTX as my primary therapy here, because it's been so aggressive and has come back so quickly.
Right.
What do you think, Amir?
Yeah, makes sense.
Yeah, I agree. He has aggressive restenosis, very short and results. So I think this would be a good case for DES.
Well, we kind of agree with that. How do you feel about how to treat it to get to that? Should you pre-dilate it? Should you debulk it again? What would you do?
Actually, I want to hear what Eric would say about treating this first.
Oh, sorry.
Hi, Jack.
Hello.
I think that a couple things I would think about. Number one, I think that DES is a good option for this. I mean, clearly it came back in a couple months, but I also think that if you IVUS this beforehand, it may show you some things that you may not have recognized before. I mean, I think that sometimes you get more information out of IVUS than you appreciate from angiographically, and I have a low threshold to IVUS this. I mean, was there some kind of plaque that maybe was undertreated, or were you into the medial wall with the Silverhawk or something like that that could have initiated the restenosis? But I think that's a question I think would be helpful to answer also.
What do you think, Mike?
Does that lesion match where the occlusion was originally?
Yes.
Must be nice to have patients that come back before it reoccludes completely. But are you?
Well, we didn't put a Viabon in. Come on.
Well, the Viabon's
Hey,
actually.
wait a minute. Come on.
Viabon's probably a pretty good option here. And any plans to check a gradient on the profunda or think about treating that?
Yeah, I kind of wanted to stay away from it, but I was waiting for someone to say fem pop so they could fix the profunda. Nobody wants to do that?
Well, you're amongst friends here in the interventional cardiology community. We don't have any surgeons on the panel right now, so you're safe for the moment.
But Jack, I mean,
unless Vinny comes, unless Dr. Kumar shows up. Well, we know what he would do.
So what we did, I don't know if you were watching there, I started the wire, and it's funny, with the glide wire, it started picking every little branch it could find. And so I just kind of brought the glide wire into an 035 Trailblazer and really just pushed a Trailblazer across all this, and it went very easily. So what we're trying to do now is get our filter down there. I think I got it halfway stuck. I'd like to put a filter down and debulk this just because really want the stent to be the last thing he has, and I don't want to have to worry about problems with the stent expansion. So I know I'm driving the cost up, but I really like to see a stent that opens nicely without a lot of help.
Are you going to change your debulking strategy?
Sorry, what was that?
Last time you used Silverhawk, so this time are you going to do something different for debulking?
Well, it's funny. We were going to use the laser for that very reason, and we thought we could call it cheaper, but they're hogging it down the EP lab to pull a lead out, so we're going to Silverhawk it.
Hey, Jack, first time you debulked and it didn't work. So what is the rationale behind debulking now? I mean, I personally think that you should just go ahead and do a long balloon inflation to see what it looks like. Since we're not going to use IVUS, and then the next step will be to put the stent, because the lesion kind of looks probably same as it was before you did the first debulking. So I really don't see any point in debulking now, since you have planned to put a drug-eluting stent.
I think that's a good.
I don't disagree with you.
I think that's a good discussion point, though, because I mean, there is no data that is going to suggest that the stent is going to do better, and so I completely see what your point is. But I've always felt that if you debulk those, the stents are going to expand better. You're going to have less stent struts sticking out into the lumen. You're going to have better opposition of the stent struts into the wall and so forth. And so I'm actually a proponent of debulking these before I put stents in. I
agree with you, Eric, but I think there's no data in the market which is basically going to show that that procedure is better than
You're absolutely right. I agree with
that. Yeah. And especially if you're putting a drug-eluting balloon, then a drug-eluting stent, then I think it's pointless.
I think, Eric, I agreed with what you said earlier. If you did IVUS and you saw something that you weren't happy with, at that stage, you're right, you could probably direct your therapy towards either debulking or whatever it may be that you decide to do, and maybe even predict why you failed the first time. But with this, I agree with Dr. Kumar. I think here the lesion looks at least angiographic, and we know angiography is a lot of lies, but it looks angiographically soft, and I think that maybe a good balloon and then take a look and then reevaluate after that may be reasonable and cost effective.
Peter is avoiding answering the question.
No, I don't disagree with any of that. I think we could easily have ballooned it, and if the balloon goes up easily, we could be happy and stent it. Or we can just go through and debulk as much as we can, and then we can watch the stent open up without a lot of help. With a medicated stent, maybe it doesn't matter so much about post-dilating and the effects of post-dilating, but we always still have to worry about the edges, and I think that's kind of the issue becomes really a cost issue. You know, we're driving up the cost here because we still don't have a single stent, drug-eluting stent that can cover all of this. So we're talking about more than one, and we're talking about spending some money to debulk what's really, and there's no cheap focal force balloon either. So
it's interesting looking at that particular vessel because if you had osteal involvement, I think that might temper my choice of therapy here. So. Between the area of restenosis and the intrinsic disease more distally,
Zilver 7x100.
If there was disease involving the ostium, I would probably think about a covered stent here because it's the one thing that you can land more precisely than anything else. And particularly since there is osteal disease in the profunda, I think there would be a bit more of a price to pay to potentially jailing the profunda here. So. Since you don't have osteal disease, I think it's perfectly reasonable to go ahead and put a couple of Zilver PTX stents here. If you did have involvement of the ostium of the SFA, I would probably lean more towards a covered stent. Now, what some people are advocating and doing, although because we don't have a drug-coated balloon, of course, is to use combination of a covered stent to take care of the occlusive long segment disease, and then using a Zilver PTX to sort of preemptively and prophylactically hopefully prevent the development of an edge restenosis. Rob Galino likes to call this, the sort of candy wrapper stent effect. So that would be another potential consideration if you had a really long lesion, particularly if it was completely occluded.
I'm just going to bring up something a little different here. I mean, we talk about so many things that we want to try. I mean, if you look at the cost of everything we're trying, right? If you say 2 Zilver PTX, $1,850 a pop, Silverhawk, say 2,400, 3,000 a pop. Then if you leave out the Silverhawk and decide to do a Viabon and followed by a Zilver, you're talking about 2,000 plus another 2,000. To me, sometimes when you're dealing with these kind of aggressive restenosis, I don't know, I'm sure all of us are very frustrated with it. I'm curious on when do we stop and say, hey, listen, you know what, let's wait for a better modality, let's wait for more trials. I know it may not be treating the patient immediately, but I'm just curious on what your thoughts are on that.
Yeah, I agree. And I think actually it has to do with the payment model, to be quite honest with you. I think as people get involved in these ACOs and, restenosis is going to be very expensive. And I think if right now it's another case for the hospital and, and the physicians, but in the future it's not going to be that way. And
I think in the future when it comes down, Jack, restenosis of the stents and restenosis of SFA will eventually go down to a femoropopliteal bypass, because the price of femoropopliteal bypass is approximately $600 for the graft. That's it. 2 days hospital stay. Most of my patients go home very next day after fempop above knee. So, what you're talking about ACOs, we look at that number now, and hammer is going to fall on us as the time goes on, because we are raising the cost up. So, I also want to generate some interest here when you see that tight stenosis at the profunda. So after putting the stent, would you treat the profunda stenosis just by plain balloon or stent, or just leave it alone?
I was not planning on touching it. I would leave that for the hopefully not going to happen, but possible surgical event in the future. Because I really don't want to deal with profunda restenosis in a successful SFA,
Well, about the comment on the fempop bypass probably becoming a standard, Dr. Kumar, I think, there's other things that are being done. Obviously, the trial that Eric has done, and I think further with drug delivery followed by debulking, we might get to the answer. I mean, I'm not giving up completely. I'm just saying in the interim, until we find an answer, how do we deal with these repeat procedures and driving up the cost? That's just my point. I'm definitely not giving up.
Yeah, and I have a lot of hope for drug-coated balloons or the scaffold. I think the scaffold's a wonderful idea. But I think something where we don't have to leave metal behind, but can get some anti-restenosis therapy would be very worthwhile, I think, and could avoid some surgeries. And frankly, a lot of the people I have taken care of, we have a patient we're doing after this. She's already had surgery and it won't stay open. And so they're not good surgical candidates, or they don't have any veins, so you're stuck with Gore-Tex. So I don't know. I'm hoping the drug-coated balloons work well and we can make good use of them. Do we have any European counterparts who can comment on their use so far?
Unfortunately, we don't currently have anyone on the panel.
My 2 cents worth on the bypass is that if it would work the first time, I would send more patients to it, but I'm always the one that's taking care of the ones that don't work, and so I'm not convinced or a fan of sending patients to bypass. I think it's easier to just dilate these. You can dilate these every month if you have to, and eventually the FDA will approve a drug-coated balloon, and then we'll have those to fix them, and it's not going to be an issue.
That's true.
And also, I think that profunda is tighter than you think it is, and I wouldn't have any problem with putting a balloon on that. If you do a low-pressure balloon inflation, even with a scoring balloon for 5 minutes or so, your chance of having any kind of acute closure, major dissection, or any problem like that is extremely low.
Eric, just a question on that thought. Why treat the profunda? The guy,
he's
a claudicant and not CLI. and you're going to get straight line flow. I'm assuming he has good runoff, so I'm just curious on why treat it.
Because I think it's going to help his downstream runoff. I mean, you're not going to, you're assuming that stent is going to stay open forever, but it may not. It may restenose. Even though it's got a drug on it, it's got a chance to restenose like everything else. I think having a profunda there is going to improve the inflow into his leg.
Why not wait and see if that happens?
You can do that too, that's fine. But I treat those routinely with balloons and I do fine.
Just worry what
Do you
happens.
use cutting balloons? Or?
Yeah, I think like that's a huge artery. I'm guessing that's a 7-millimeter artery looking at it. I mean, if you put a 6-millimeter cutting balloon on it and stayed up for 5 minutes, you'd have a great result.
You know, there is one other potential treatment option that we actually haven't talked about, and that is adventitial delivery of drugs, either anti-inflammatory drugs like dexamethasone or paclitaxel or the sirolimus drugs. You know, there's a very provocative study that was published, I'm very proud to say, by one of my former fellows, Chris Owens, who is the Associate Chair of Vascular Surgery at UCSF, and Chris did an elegant study at the VA out there where he took 20 patients with SFA disease, and he treated them with angioplasty and atherectomy with provisional stenting. Average lesion length was about 10 centimeters,
That's 6
and he found that only 2 out of 20 developed restenosis. And this was after he finished treating the vessel. He used a microinfusion catheter called the Bullfrog, made by a company called Mercator. And it's basically like 1 atmosphere balloon, which when inflated pushes a very, very tiny needle into the wall of the artery to deliver dexamethasone into the adventitia. And Chris's rationale and his hypothesis was that inflammation is the first step of engendering restenosis, and if you can potentially inhibit that step right up front, you may reduce the risk of restenosis. And in fact, there is now a multi-center feasibility trial going on in the United States called the DANCE trial, which is in fact examining the use of dexamethasone for patients and just like this. The next DANCE trial is actually going to be looking at a limus drug as well, and perhaps that may overcome the negative findings of that STRIDES trial that was published a number of years ago. So obviously, there are many ways to skin the cat, so that potentially might be yet another option in the future for our patients. So Jack, bring us up to speed here.
All right. Well, if you can probably hear the cash register in the back dinging every time, but we're on our 3rd drug-eluting stent. And we're going to balloon this with our cheapest possible balloon, and we're going to be done, I hope. So we did luck out and get a couple of 100 millimeter long Zilver PTXs. So we have 2 100s and 180, and we stayed away from the ostium. And you can see, even with doing, now we didn't do a real aggressive Silverhawk. I didn't want to put a Viabon in because I got too crazy. But it's taken us how much? We're about 6 atmospheres here, and that looks reasonable. You can see there's the top part there. That's kind of why I wanted a Silverhawk, because that was after we debulked a little bit, and the top part isn't opening all the way without probably going to take a little more pressure. Why don't you go? Actually, no, hold on. We'll do that when we pull back a little bit. Maybe not. Let's come down. So what he's pointing at is the distal end there. We didn't take the balloon all the way down. I'm trying to avoid an edge problem, so maybe I'm going to create an edge problem by not treating it. So we're probably going to have to go down a little bit more distal. Why don't you go up there just to 2 atmospheres? Hold on a second. Right there.
So I'd like to ask the other members of the panel their experience with Zilver PTX and the delivery mechanism. I have to say that's been one of my pet peeves is you have to basically really make sure that you put some forward pressure with your right hand as you're desheathing with your left hand to overcome that initial inertia. I'm happy to report that Cook is coming out with a brand new mechanism for deployment of the stent, which I think is going to make a lot of people happy.
Well, originally they were telling us we had to use Amplatz wire, but we kind of quit doing that quickly. You can go up there. But you're right, there's quite a bit of stiffness trying to get it started, but eventually it comes out just fine.
The whole discussion for the session here has been, not how do we get a good, safe result, it's how do we sustain it. And, there's a lot of potential answers out there. Nothing definitive as of yet, but I think there will be.
What size balloons you use there, Jack?
This is a 6 by 200 power cross. So even with debulking, like I said, we didn't do it aggressively, but you can see that there's parts of the stent that aren't as well open as other areas, even with getting them open with the balloon. So I don't know. Hopefully the medicine will overcome that, but if we hadn't done some, I fear it may have looked a little worse. All right, let's go ahead and take this out, take our filter out. Let's just use the blue thing. So we did use a filter because we were debulking. I wanted to protect it, and we're going to get that out in a second, and we'll take some final pictures. I guess what I was referring to before the surgery argument was that, hopefully we can get to a place where we can get good long-term benefit on these with anti-restenosis, and the extra cost up front pays off over time, I hope. I have had a couple of cases where we tried to save some money and we put one Zilver in and then finish with another stent, and as they come back, the regular stent is restenosed and the Zilver is wide open. So we probably would have saved more money throwing one more stent in at the beginning.
I think part of the challenge is for Cook to really start producing stents that are real-world lengths, and that will also help us to utilize it more often. I think as we've seen by the talks given today that the real-world lesions are much longer, and it's important that they come out with the longer stents.
I asked them for a 300 millimeter stent last night, and they laughed at me.
Oh boy, we got a vibe on this 250, right?
Right.
They will make 3 100s
All right, hold
if
still.
you want. They will make 3 100s if you want.
Yeah.
Now, they do tell me that they are, once the FDA gives the nod, they will have 150 millimeter lengths available. Looks pretty nice there, Jack.
This looks good. I like that the stents are away from the ostium, away from the adductor canal. I think they're going to do fine. Kind of small arteries down there, but they wake up.
That looks great.
You got it timed right.
Jack, you think you could show us that common femoral bifurcation with a lot of LEO, just to sort of show that bifurcation a little bit more clearly?
Yeah, let's see if we can get a good shot of it here. He's trying to leave. We're not done yet. Oh, I'm gonna spray this groin. He's trying to remove his sheath for us. So the little movement there, but it's it's probably significant. But I'm having a tough time being talked into fixing it.
Yeah, the ostium of the SFA actually looks fine, so I think the consensus of the panel, minus the guy from Iowa, is probably to leave the profunda alone for right now.
Yeah, I think we'll do that. All right.
Okay, Jack, that was
That's all we got for you.
that was an excellent demonstration, and not only was that a terrific case, but you also are to be commended for actually finishing on time.
For once today.
Yeah.
right?
So thanks to you and your whole team, and I think
Right.
that's actually all the time that we have for the session. So I'd like to thank everybody for attending and for a great
right,
discussion in the
thanks.
panel. All right, thanks very much.
Thanks, Jack.